Hello, I am Lisa Garner, and I'm a mortgage loan officer in Conway, Arkansas. I am a grandmother of 3 wonderful grandbabies, married to a wonderful man for 34 years, and from that we have 3 wonderful children. I have been able to manage kidney disease for the last 50 years. I am currently 10 months post-transplant from my second kidney. I have been in-center dialysis. I have also done peritoneal home dialysis, so very familiar with both dialysis. I'm honored to serve AAKP as a member of AAKP's National Board of Directors. Being a board member of AAKP is very special to me. It has given me a voice so that I can help others that are in need through kidney disease, organ donation awareness. Today I'm pleased to introduce Dr. Janice Lee, Professor of Medicine at Emory University and Chief Medical Director of Emory Dialysis in Atlanta, Georgia. Dr. Lee serves on AAKP's Board of Directors and is a recipient of AAKP's Samuel J. Ornstein Award for Extraordinary Service. Dr. Lee will present on coronavirus, accelerating the adoption of telehealth and telemedicine. We appreciate Dr. Lee for taking her time to share insights on utilizing telehealth and telemedicine during a global pandemic and how timely research and innovation can improve patients' lives and society.
Good morning. I am Dr. Janice Lee from Emory University, also AAKP board member. I'd like to thank the AAKP and GW University for inviting me to speak on this global summit. My topic is on telemedicine and the coronavirus pandemic. The objectives are to define telehealth/telemedicine, review the CMS rules and allowances for telehealth, and then lastly, discuss how telehealth is used in the outpatient and inpatient settings, including the dialysis centers. So this first slide is just giving us the definitions because you'll hear the term telehealth and you may hear telemedicine just to make it clear the differences. Telehealth is really the umbrella term for all services that provide some type of technology. It's a collection of methods for enhancing public health or health education by telecommunications technologies. Examples of telehealth are public health apps that alert the public of a disease or outbreak, and video conferencing platforms for medical education. Telemedicine specifically refers to clinical services. So this is basically what is involved with patient care. It involves a clinician providing a medical service. And this could be via several mechanisms, mobile apps that lets the physicians treat patients remotely via video chat, or software solutions that lets the primary care providers send photos to other physicians. One of the more popular areas this is used is in dermatology for skin disorders. This is a cartoon that was published in the New England Journal of Medicine this past year. Again, looking at the various forms of telemedicine tools and services. You can see first is just the clinician to clinician, where the physicians may communicate to each other either through email, video, or both. Certainly phone calls would fit there. Clinician to patient, several mechanisms: video, phone, email, remote wireless monitoring, and using the internet. And then there's the patient to mobile health technology, which is very popular these days, where the patients themselves can have apps that record their blood pressures, pulse rate, etc. So they can wear certain types of wearable monitors. They can use this on their smartphones. Also have video, email capability, and web portals. So the purpose of telemedicine in COVID, as we all know, we've been in a very serious pandemic that has limited a lot of contact in all areas of our lives, including medical appointments. So there's been an urgency to expand the use of technology to help people who need routine care and at the same time keeping vulnerable persons and those with mild symptoms in their homes while maintaining access to the care that they need. So there was an expansion of telehealth with the Centers for Medicaid Services, or CMS, via an 1135 waiver, also called the CARES Act. And under this waiver, because of the pandemic and the need for patients to be able to access their usual health care, this waiver allowed for Medicare to pay for office, hospital, and other visits furnished via telehealth across the country, and including in patients' place of residence. And this all was enacted March 6, 2020, in the midst of the pandemic. Now, prior to this waiver, there were some limited telehealth services that Medicare would cover, but the patient had to be in a rural area, meaning they're far away from most of their healthcare facilities, or the patient had to leave their home and go to a nearby clinic or hospital or some other type of medical facility to be able to receive the service where they could actually remotely see a physician that is miles away, but they had to travel to a clinic. Now, with this waiver in the midst of the pandemic, Medicare beneficiaries will be able to receive and have been receiving a specific set of services through telehealth, including evaluation and management visits, which is what we usually, the term used for common office visits, but also mental health counseling and preventive health screenings as well. And then the main highlight of this waiver was that these visits could occur in the patient's home and not just limited to rural areas. There were other types of telehealth that were available even before COVID. I already mentioned the rural areas where patients could access physicians or other medical personnel, mostly if they traveled to another healthcare facility. There also were other ways in which Medicare was covering on a limited basis some remote patient communication, such as virtual check-ins. And these would be really phone calls where the patient initiated a call to a physician's office, and there would be some allowance for billing and reimbursement for those. Also, Medicare was supporting some electronic visits or e-visits, which were non-face-to-face patient-initiated communications through an online patient portal. So these were areas that were just being explored and in use prior to COVID, and now have been much more expanded since COVID pandemic. Now, this is a busy slide. I just have it here to highlight the different types of services that CMS has allowed in the wake of the pandemic. The first one is the Medicare Telehealth Visits, which is when the provider sees a patient via telecommunication systems, and that these patients could be seen in the office, and also in the hospital. These were codes for outpatient and inpatient billing. Then you also have the virtual check-in, which is a brief 5 to 10 minute phone call. It could be longer. If the physician records the time, the billing code may be a little bit higher. And then the electronic visits through the online portal. All of these mechanisms were approved with the CMS 1135 waiver in the midst of the pandemic. As we all know, some patients may not have access to smartphones or other types of web-based communication technology such as Zoom, Skype, etc., FaceTime, and therefore some of the patients will need to be seen or have their visit conducted via the phone. And so all of these measures of communication were approved so that the physician and the provider could also be reimbursed for these services. Now, this is a very busy slide. I don't expect you to read all of this, but I just wanted to give you this document just to explain for inpatient visits in the hospital. CMS allowed inpatient visits also to be conducted via telemedicine, primarily because of the one particular advantage would be to be able for the providers in the hospital to be able to use the less protective equipment, and also to limit provider and patient exposure. And so then a patient could be seen remotely via Zoom and FaceTime with their physician that has been consulted on them in the hospital. The benefit for the physicians were that the reimbursement was equal to seeing the patient actually in the room, whether they were using FaceTime. Some hospitals were using baby monitors to communicate with some of the patients, even if they were in the hospital, or they could be at a remote site at their office, at home, etc. All of these methods were all reimbursed equally. So this was a great way to limit exposure to the providers, the physicians, as well as the patients from having extra persons in their room, and to limit any other exposures. The other point I want to mention here is that this was not just exclusively for COVID positive patients. This was allowed and is still being allowed for all patients. And the important message there is that obviously the other patients in the hospital who are not COVID could be potentially exposed to other medical personnel who have been in contact with COVID patients. And so this mechanism allowed uh, those patients to be protected as well. And then the third issue was if there, and as we know in many states, there's been a shortage of medical personnel who've fallen ill with COVID. And so this would allow patient or physicians to help increase the workforce to be able to provide appropriate services, even if done remotely, because they were either on quarantine and couldn't come into the hospital, etc. This is just a disclosure, what we call a dot phrase, that every encounter for patients seen via telemedicine, the physician has to document that this was a particular visit conducted during the COVID-19 outbreak. You've discussed with the patient the nature of the telehealth visits, i.e., the patient has to consent to being seen by telehealth. If they don't want to do it that way, then you cannot legally do that. And so you would just make this disclosure as to why you're doing it, and that you're evaluating the patient based on your and making recommendations and treatments based on your assessment. You have to make sure that the patient knows that their personal health information is being protected, that there's no recording of sessions, and that the team would provide follow up care in person if and when the patient needs it. So, to make sure that the patient is getting the best care possible via this telemedicine platform. So, under the telehealth waiver, various platforms were allowed to be used um, without any concern for HIPAA violations, again, because of the urgency to get care to patients. Almost any platform was allowable, such as Zoom, FaceTime, Doximity, Skype, and GoToMeetings. Now, in addition to outpatient telehealth visits and inpatient hospital visits, CMS also allowed for outpatient dialysis visits. So this was really, I think, a very strong point from from the CMS allowance, because this has never happened before in center dialysis for rounds to be able to be conducted via telemedicine. We certainly had some familiarity with this for home dialysis patients, where patients were allowed to be seen at home remotely every quarter or so. Every two visits would have to be in person on a monthly visit, and then the third visit would have to be in person, but 2 out of 3 visits could be done by telehealth. But with this CMS waiver, it now allowed for patients in center to be rounded on all 4 visits. We do 4 weekly visits for a total of 4 per month, and they allowed us to do that for every visit. The only thing that we could not do and cannot do is phone visits for these in-center patients, like you can for the outpatient in your general clinic. These had to be by telemedicine, so you had to have some video capability of seeing the patients. So, what does a telehealth visit in the inpatient dialysis unit look like? Well, you, with the FaceTime or Zoom, whatever platform you're using, we have the dialysis nurse who's already there in the clinic go around with the iPad, is for example, is what we use in our clinics. And you can see and talk to the patient just as if you were there in person. You can do a key physical exam. You can look at their legs for edema. You can look at the vascular access, visualize any particular abnormalities that the patient expresses. There's also electronic stethoscopes that are available. I wouldn't say this is widespread use, but it is available for those who can use it. It's not a requirement, however. But you also have the nurse there who can also examine the heart and lungs if the physician needs that to be done. You can always look at the dialysis machine. I have the nurse direct the camera to the dialysis machine, just as if I'm there. I can see what the blood pressures are. I can see how much fluid is being removed to decide if it's too much or not enough. See if there's any particular things of concern, if the blood flow is not meeting the target goal, etc. We're also using this platform to conduct the interdisciplinary rounds for the dialysis unit with the dietitians, the social workers. Many of you are are familiar or may know that many of our ancillary staff in the dialysis units, to avoid unnecessary exposures for themselves and the patients, have been working remotely from home, and so they can actually communicate with the patient via this platform, and that we can all get together with the physician, a nurse, dietitian, social workers, and do our usual monthly rounds that we usually do, so that the patients really are getting the full service of what they're used to, but in a remote fashion. I can even, when I'm using Zoom, we can actually share the screen. This is really ideal for the home dialysis patients, and actually can show them in real time all of their laboratory data and review that, again, as if you were right there in person. This is just showing you the technology that is available to conduct telemedicine visits, and particularly for nephrology patients. On the left, of course, is the iPad that you would use for FaceTime. In the middle is the electronic stethoscope, and this is pretty neat if physicians have access to this. But the nurse can actually put the stethoscope on the patient, and the lungs and heart sounds can be transmitted electronically through a web-based application, and so you can actually hear their heart sounds. So it's a really great tool. And then on the right is just your dialysis machine. This is particularly for home dialysis, this particular machine that I have illustrated here. And then this is your traditional machine that you would see in the dialysis unit with the screen. And so I just showed this to show you that this is exactly what we would be looking at when we're physically in the dialysis unit. So we can really review the patient's session and provide the best care for that clinic visit that we would if we were in person. This is just information about the electronic stethoscope. It allows live streaming of heart and lung sounds. There's a link that's sent by email or text to the provider. We particularly have had experience with the Echo app. There's also a Littman stethoscope, etc. And again, these sounds can be recorded and sent to providers so that they can evaluate the patients if there's any concern for any abnormalities in their heart or lungs. But again, this is not required by the CMS guidelines for telemedicine, but it is something that can be done to provide really great care and assessment of the patients. So why do we use telemedicine in the dialysis centers? Well, the same reasons as we talked about earlier. We can preserve the personal protective equipment that we all know has been in short supply. We can reduce medical staff exposure and minimize exposure of patients to healthcare workers, because many of the nephrologists, for example, are still rounding in the hospitals, and so they could have potentially been exposed. So it's really, I think, a win-win for everyone to be able to have this capability of using telemedicine. Again, it maximizes the utilization of the provider workforce in case there is a large number of physicians, nurse practitioners that get ill with COVID or have to be quarantined for any specific period of time. Again, we can conduct cyber rounds, interdisciplinary rounds with the other ancillary staff, dietitians, social workers, and even use this for family meetings. So because we have limited visitation in the dialysis clinics, the family members can't really come to the clinic during the COVID pandemic. So we could also communicate with them as well. And then obviously, we are still in the pandemic. We don't know how long this is going to last. We don't know if we're going to have future pandemics, etc. So it's great for us to be able to work out this process and perfect it, so that we can apply this in the future. And hopefully, the lessons learned from this will allow us to be able to be more efficient, and provide, really good care to our patients. For example, even outside of COVID, if a physician isn't present in the dialysis unit and there's a particular problem with the patient, or something that needs to be visualized, we could use this equipment to be able to communicate with the nurse and with the patient remotely and help decide whether or not patients need to go to the hospital, to the emergency room, or if they can wait to go for an outpatient clinic visit. So I do believe this is going to be something that we will see some form of in the future, even beyond COVID. So, in summary, as far as our focus on telemedicine, just a few highlights. Telemedicine no longer has to be from a rural location. It can be done right in your current settings with your current local providers. It applies to all evaluation management visits, either inpatient or outpatient. Also, it can apply to mental health visits and preventive health screenings. And again, these E&M visits for all types of physicians, not just any certain specialties. Every single specialty is covered. It can now be delivered from a patient's home or any healthcare facility. For the dialysis application, again, it cannot be via phone. So for the patients in center, it needs to be some audio-visual component. But again, for outpatient general clinics, mostly I think these these visits are being done audio visually, but again, and for people who don't have adequate access to smartphones, etc., you can communicate with your physician either via a phone call or an online portal, and every that is covered as a visit that can be reimbursed for the providers. Physicians, nurse practitioners, PAs, nurse midwives, certified nurse anesthetists, clinical psychologists, social workers, dietitians, nutritionists, all of these professionals can provide services via telemedicine according to the CMS waiver. And so this is the last slide I have. As Dorothy says in The Wizard of Oz, there's no place like home. I think we've all learned from this pandemic that there is a lot that can be accomplished at home, and that you can get adequate health care as well. Certainly for the in-center dialysis patients, they do have to go to the dialysis unit, but they're still able to get the care that they need and communicate with their physicians, dietitians, social workers. A couple of quick points I wanted to make. I've heard that the dialysis patients really like some of the way we're doing the telemedicine rounds. They also like being called at home, which is what is happening for the dietitians, for example, to review their monthly labs. And they feel like they're getting more privacy that way, and they can actually talk longer, and staff can spend more time with them. So I do think there's a lot of positive benefits from this telemedicine model that we are in now. And just remember that, we are all in this together, and this whole telemedicine initiative was to try for us to be able to function, make sure that adequate health care is being provided. It's not a substitute for the old way we did things, but it's something we had to implement in order to get everyone properly cared for. And I am happy to answer any questions. I have my email address here if anyone wants to contact me in the future for any more information. Again, I want to thank the AAKP and GW University for inviting me to speak. Thank you.
Dr. Lee, we sure appreciate your time today and sharing your insights on utilizing the telehealth and telemedicine.